Welcome to the second lecture in our Aerospace Medicine Seminar Series. Today we will be covering aerospace medicine environments. My name is Natasha Cho, one of the core faculty members of the UTMB Aerospace Medicine Division. I am board certified in aerospace medicine and emergency medicine and a 2015 graduate of the UTMB Aerospace Medicine Residency. This lecture was updated and prepared by Dr. Craig Kutz, board certified in emergency medicine and undersea and hyperbaric medicine, and a 2024 graduate of the UTMB Aerospace Medicine Residency. This presentation uses material from the original mini-series curriculum and expands upon it in the 2024 update. Our residency and associated projects are funded in part by NASA. As a disclaimer, the content in these presentations serves as a basic introduction to aerospace medicine concepts for students. It is not a substitute for formal ACGME-accredited aerospace medicine training or aerospace medicine work experience and shall not be used as such in medical practice or decision-making. This material, including text, images, and multimedia, is protected by copyright and other intellectual property laws. The content is provided for informational purposes only and may not be copied, reproduced, distributed, transmitted, displayed, modified, or otherwise used in whole or in part without the express prior written permission of the University of Texas Medical Branch at Galveston. Today we will cover the following objectives. Before we discuss the layers of the atmosphere, it's important to understand that as altitude increases, ambient pressure decreases, as shown in the illustration here. Volume for a fixed gas would also increase as you increase in altitude, according to Boyle's law. However, this will be discussed in more detail in a separate lecture in this series. Decreasing pressure with increasing altitude results in the molecules of gas being more spread out, also known as decreased air density. This is what is referred to when you hear the colloquial phrase, the air is thinner. It is important to realize that the percentage of gases in the air remains constant as altitude increases. For instance, at the summit of Mount Everest, there is still 21% oxygen in the air. But because the pressure has decreased, those molecules are more spread out, which makes it feel as though there is less oxygen. This is why most people climbing Everest use supplemental oxygen. This is also why, if a commercial airplane depressurizes, the oxygen masks fall to be made available to passengers to use. And this is also why astronauts must wear spacesuits that provide them with gas to breathe in the vacuum of space. Atmospheric pressure is equivalent to a 1 meter square column starting at the Earth's surface. Because pressure is directly related to force divided by area, the pressure decreases the higher up you go. At sea level, the weight of the atmosphere is 14.7 pounds per square inch, or psi, which is equivalent to 760 millimeters of mercury, or 1 atmosphere. Knowing what we know about pressure decreasing with increasing altitude, let's look at the chart on this slide. This illustrates the decrease in pressure with increase in altitude that we discussed with respect to sea level. We can see that at 18,000 feet, we have approximately half the atmosphere that we do at sea level, approximately 1/4 of the atmosphere at 34,000 feet, and approximately 1/8 of the atmosphere at 48,000 feet. At 18,000 feet, since we have half an atmosphere, it will feel like there's half as much oxygen, even though, as we discussed on the previous slide, that the percentage of oxygen remains the same. 63,000 feet represents a significant altitude known as Armstrong's line that we briefly mentioned in the first lecture. The pressure at this altitude is the same as water vapor at 37 degrees Celsius, which is human body temperature. We'll discuss the aeromedical implications of this shortly. As we increase in altitude around 2,000 to 3,000 feet, one's oxygen saturation will start to decrease due to the lower partial pressure of oxygen in the atmosphere. This is why the FAA has requirements regarding supplemental oxygen for flight crew in unpressurized aircraft above certain altitudes. Now let's discuss the layers of the Earth's atmosphere and why they matter to an aerospace medicine physician. The layers of the atmosphere in order from the Earth to space are the troposphere, the stratosphere, the mesosphere, the thermosphere, and the exosphere. Cooling at the poles lowers the altitude of each atmospheric layer, so each layer is thickest at the equator. Let's look at each layer in more detail. The troposphere is the layer closest to the Earth and extends approximately 5 miles upwards. This is where we live and where weather exists. Tropos is Greek for turn or change, and troposphere is named for constantly changing weather. We talked about the pressure decreasing with altitude. So 75% of the mass of all 5 layers of the atmosphere is contained in the troposphere. There's a steady decrease in temperature in the troposphere of 2 degrees centigrade per 1,000 feet of altitude gain. This is known as the lapse rate of the troposphere. For added context, in an unpressurized aircraft above 14,000 feet, which lies within the troposphere boundary, the FAA requires supplemental oxygen to prevent hypoxia. The tropopause is the region between the troposphere and the next layer of atmosphere called the stratosphere. The tropopause is at approximately 35,000 feet. Here, the temperature is relatively constant at lower temperatures, making aircraft efficiency high, and is the reason that most aircraft cruise at altitudes of around 35,000 feet. The stratosphere is above the troposphere and tropopause. In this layer, temperature increases and convection exists. Due to convection, the stratosphere experiences stratification, hence its name. The ozone layer is also contained in the stratosphere. The other demarcation of relevance in the stratosphere that we must discuss is Armstrong's line. Armstrong's line occurs at an altitude of 63,000 feet and is the altitude at which the ambient pressure is so low that the boiling point of water is equal to body temperature, or 37 degrees Celsius. This can result in a phenomenon called ebullition for unprotected humans, in which the fluids in the body will literally boil. What we have discussed so far highlights the necessity of the medical team specialized in aerospace medicine to keep aviators and astronauts safe due to the changes in temperature, pressure, and the risk of ebullition that are faced by pursuing higher altitudes. The photo on this slide is SOFIA, NASA's Stratospheric Observatory for Infrared Astronomy. Essentially, they open the door to the aircraft to collect data from the stratosphere, minimizing interference from weather and the thick atmosphere of the troposphere. This is a graphic of Armstrong's line placed on the layers of the atmosphere for your reference. The mesosphere is the next layer of the atmosphere. It is aptly named because it is in the middle of the 5 layers. This is where meteors burn on entry into the Earth's atmosphere. The coldest temperatures in the atmosphere are also found at the top of this layer. The next layer is the thermosphere. Thermos is Greek for heat and refers to the high energy UV radiation absorbed in this layer, causing extremely hot temperatures. However, the molecules are so far apart that there are also extremely cold temperatures in the thermosphere. The Kármán line, sometimes known as the von Karman line, is also in this layer and demarcated at 100 kilometers of altitude. This is the altitude at which ambient pressure is so low that aerodynamic controls and lift will fail, and rockets are required for maneuvering. The Kármán line has also been used as a designator for space travel, and those who cross it are considered astronauts. Weightlessness is also experienced past or above the Kármán line. As indicated by the photos, the atmosphere in the thermosphere is heavily ionized near the poles, resulting in auroras. The International Space Station sits in the thermosphere, and the curvature of the Earth is visible from this altitude. Here we see both Armstrong's line and the Kármán line. Note that Armstrong's line is depicted in feet, whereas the Kármán line is depicted in kilometers. The exosphere is the final layer of the atmosphere. It is so expansive that it is nearly as thick as the diameter of the Earth. In this layer, molecules can travel hundreds of miles without ever colliding. This is where satellites such as the Hubble and James Webb telescopes orbit. Now we are going to discuss medical concerns with operations at high altitudes, including acute mountain sickness, high altitude cerebral edema, or HACE, and high altitude pulmonary edema, or HAPE. To understand altitude illnesses, it is important to understand that the human body responds to lower oxygen levels at altitude by sensing our ability to exhale carbon dioxide. This is sensed by various baro and chemoreceptors in our body, including the aorta, carotid body, and most importantly, our brainstem. Note that the brainstem receptors are not pictured here. At what altitude can we expect the human body to respond to lower oxygen? When we reach an altitude of approximately 2,000 meters or 6,500 feet, the partial pressure of oxygen is low enough to cause our body to undergo what is called the hypoxic ventilatory response. This occurs at a partial pressure of oxygen of about 70 millimeters of mercury. In the very simplest of summaries, this is how our body senses carbon dioxide and causes us to hyperventilate. When we climb in altitude, we start to hyperventilate to get more oxygen and thus remove more carbon dioxide. Our chemoreceptors sense this change in carbon dioxide, which results in the hypoxic ventilatory response. Let's look at some risk factors that place people at higher risk for having problems at altitude. Rate of ascent is an important risk factor, particularly with a quick rate of change in sleeping altitudes. Certain chronic medical conditions, such as pulmonary hypertension, also increase the risk of high altitude pulmonary edema, or HAPE. We are covering a lot of concepts in this lecture, so it's beyond our scope to have an in-depth discussion of pathophysiology of chronic medical conditions as they relate to mountain illness. Briefly, however, it's worth mentioning that fast rate of ascent leads to inappropriately slowed hypoxic ventilatory responses. VO2 max, which is the maximum rate of oxygen consumption during exercise, also decreases by 10% for every 3,281 feet above 5,000 feet. The worst case scenario of altitude illness is vasogenic edema, which is the underlying cause of HACE and HAPE. Acute mountain sickness, or AMS, is one of the most common diagnoses seen at altitude. Diagnosis requires the presence of a preceding high-altitude headache, plus at least one of the symptoms listed here. Of note, poor sleep was a symptom removed as a criterion in 2019 due to the high prevalence of sleep disturbances with altitude, unrelated to mountain sickness. AMS is often a delayed presentation, approximately 4 to 36 hours after reaching altitudes above 8,000 feet. The incidence of mountain sickness varies depending on the source you reference, however, has been reported in nearly 50% of individuals unacclimatized in the Himalayan mountains. Incidence increases in patients flying from low to high altitudes because the relative change in altitude is fast. The treatment for AMS is to stop ascending immediately. Mild cases can be treated with supportive care and may even continue ascending if symptoms completely resolve. However, if they do not resolve, this can indicate severe cases, which should immediately descend. Treatment adjuncts such as oxygen, acetazolamide, and dexamethasone can also be used. Oxygen treats the low partial pressure of oxygen. Acetazolamide, also known as Diamox, is a carbonic anhydrase inhibitor that causes excretion of bicarbonate, resulting in alkalinization of the urine. This in turn results in a metabolic acidosis that offsets the respiratory alkalosis that occurs on ascent. It stimulates respiratory drive, in turn increasing oxygenation of blood, resulting in faster acclimatization. Dexamethasone is a potent steroid that decreases the inflammatory processes that take place in cerebral and pulmonary edema. It is very important to not ascend if you have symptoms of mountain sickness, as this could lead to development of the next mountain illness we are going to discuss. High altitude cerebral edema, or HACE, is a medical emergency. HACE is almost exclusively preceded by AMS and develops in individuals who often did not heed their symptoms as we previously discussed. HACE is indicative of acute neurologic disease, with symptoms listed here including altered mental status, ataxia, and other neurologic deficits. Although rare below 2,500 meters, cases have been reported. HACE is thought to be in part due to brain swelling from vasogenic and cytotoxic edema. The clock in the lower right of this slide represents a mental status exam from an actual patient seen by Dr. Craig Kutz that was diagnosed with HACE in the Himalayan mountains. The best and frankly only treatment for HACE is immediate descent. The patient should be accompanied if at all possible, as many fatal cases of HACE were due to secondary falls. If descent is impossible due to weather or other circumstances, a portable altitude chamber can be used as long as the patient's airway can be protected. Other treatment adjuncts include oxygen and dexamethasone. Equal in severity to HACE is high altitude pulmonary edema, or HAPE. HAPE can be more insidious in onset because it does not have to be preceded by AMS. The signs and symptoms are what you would expect based on the pathophysiology of vasogenic edema in the lungs, but in particular at altitude can be associated with extreme fatigue. A good example would be a hiker who is normally in the front of the group but is now struggling to keep up. HAPE is a non-cardiogenic pulmonary edema caused by heterogeneous pulmonary vasoconstriction. It is theorized that there may be a genetic predisposition to HAPE. However, heavy exertion or concurrent upper respiratory infection can also increase your chances of developing it. HAPE is also a medical emergency. The treatment, again, is immediate descent. If possible, the patient should ideally not exert themselves, as exertion can lead to worsening symptoms. If descent is impossible, a portable altitude chamber is acceptable as long as the patient's airway can be protected. Adjuncts to treatment include oxygen and nifedipine, a calcium channel blocker that results in decreased pulmonary arterial pressure. Although positive pressure ventilation has shown promise in small trials to improve oxygenation, there is no evidence on patient long-term outcomes reported. Finally, this is not fluid overload, and therefore diuretics should be avoided. In fact, using diuretics has been shown to make HAPE worse. The good news is that in most cases, careful planning can prevent altitude illnesses. Flexible itineraries that allow for extra time at altitude to acclimatize are crucial. Patients should sleep at altitudes lower than their operations, also known as the train high, sleep low philosophy. Diets rich in carbohydrates can help elevate the respiratory quotient. Anything that slows your breathing rate or ventilatory response should be avoided, such as sedatives or alcohol. We've discussed the mechanism of action of acetazolamide previously. It has the best evidence for prophylaxis for anyone with a history of AMS or who will be ascending above 8,000 feet. The dose is 125 milligrams by mouth twice daily. It should be started one day before ascent and stopped either on descent or 48 to 72 hours after reaching maximum altitude. Dexamethasone can be used for prevention, but is not frequently used due to the risk of side effects or masking the symptoms of mountain sickness. Nifedipine, a calcium channel blocker, can be used 30 milligrams twice daily for HAPE. Sildenafil and other phosphodiesterase inhibitors cause the production of nitric oxide, resulting in vasodilation of the pulmonary vasculature, decreasing pulmonary resistance, and can prevent HAPE. Now we are going to discuss heat illness with regards to heat cramps, heat exhaustion, and heat stroke. This is a photo from the New Mexico wilderness during a search and rescue operations training. First, let's consider thermoregulation of the body. Temperature increases in two ways: endogenously through increased muscle activity and metabolism, resulting in heat as a byproduct, and exogenously from ambient temperatures that are higher than body temperature. The body employs countermeasures in an attempt to keep itself cool, such as peripheral vasodilation and sweating, but these countermeasures have limits. Heat illness is a spectrum. The most mild form is heat cramps, which involve cramping of the muscles during or immediately after exercise. It is self-limited when exertion stops. Heat exhaustion is more serious and can occur at body temperatures above 39 but less than 40 degrees centigrade. It can be overcome by the body's countermeasures as long as activity is stopped and the patient is able to retreat to a cool environment. Heat stroke is the most severe manifestation. Rectal temperature greater than 40 degrees Celsius and altered mental status are diagnostic. It's critical that the temperature be rapidly lowered, as heat stroke will not resolve without treatment and can be life-threatening. Risk factors for heat illness are listed on this slide. The wet bulb globe temperature is what is used to monitor conditions for activities like marathons, as it incorporates humidity, air temperature, and radiant heat into its measurements. A wet bulb globe temperature of 28 degrees centigrade corresponds to 82 degrees Fahrenheit with 100% humidity. The symptoms of heat stroke can range from subtle, such as headache, dizziness, and weakness, to more obvious, such as nausea, vomiting, seizures, and loss of consciousness. Early intervention is critical to the survival of the patient with heat stroke, and clinicians must maintain a high index of suspicion. Heat cramps can be treated by stopping the activity, seeking cooler temperatures, drinking, and stretching. Heat exhaustion can be treated in the same fashion, incorporating fans for evaporative cooling. Stretching is not necessary in the treatment of heat exhaustion. Heat stroke is a medical emergency. The ideal treatment is whole body immersion in ice water. This should be done prior to evacuation because patients can worsen or die during evacuation. Immersive cooling should continue until the rectal temperature is less than 39 degrees centigrade, and the patient should be monitored until the rectal temperature is less than 38 degrees centigrade. Patients should not exert themselves for 24 to 48 hours after treatment and should be hospitalized if they experience a loss of consciousness or if they do not respond to cooling, or if their temperature rises within 1 hour after cooling. Again, with careful planning, heat illnesses can be avoided. Encourage patients to drink to quench their thirst. Clothing should be appropriate for operational environments. You can see in this photo that Dr. Krakis is wearing lightweight, light in color clothing that provides protection from the sun. Medications with anticholinergic side effects should be avoided. Perhaps most importantly, from an operational standpoint, is acclimation to heat. It is advised that patients acclimate for 60 minutes a day for 2 weeks in similar heat and humidity to their operation prior to full deployment. Regarding operations in cold temperatures, we will next discuss hypothermia, frostbite, and frost nip. The body loses heat through conduction, convection, radiation, evaporation, and insensible losses. Listed here are the various types of heat loss. Countermeasures the body employs include peripheral vasoconstriction and shivering, but these strategies have limits. Nearly 50% of heat loss at lower temperatures is due to radiation heat loss. Hypothermia corresponds to a rectal temperature below 35 degrees centigrade and is a spectrum of signs and symptoms. Risk factors are listed on this slide. Mental illness and use of alcohol are the most common predisposing factors because they impair judgment. In reality, the lines between mild to moderate and moderate to severe hypothermia can have a lot of overlap. In general, if a patient's core temperature is within the parameters listed on the previous slide and they are not shivering, this is considered moderate to severe hypothermia. The treatment for mild hypothermia is passive external warming, removing wet clothes and applying dry clothes or blankets. If you cannot remove the wet clothes, wrap the patient in plastic all around their clothes and try to seal it off. Warm drinks should be ingested, and hot water bottles, heating pads, or heated blankets should be applied directly to the trunk or axilla. Moderate hypothermia requires active internal warming, 40 to 42 degrees Celsius, or 104 to 108 degrees Fahrenheit. IV fluid resuscitation is preferred with D5 normal saline. Humidified oxygen can also be provided. Avoid lactated Ringer solution, as the liver cannot process LR at this degree of hypothermia. Severe hypothermia requires active internal warming in the ICU. This includes warm lavage of the peritoneal, thoracic, and gastrointestinal spaces. External warming must be deferred until internal warming is complete to prevent peripheral vasodilation, resulting in cardiovascular collapse from warm blood returning to a cold core, causing dysrhythmias and shock. Advances in field ECMO in severe hypothermia have revolutionized out-of-hospital care. Frostbite occurs when body tissue freezes. Circulation in the area decreases secondary to vasoconstriction and increased viscosity of blood in freezing temperatures. Water is drawn out of the cells and ice crystals cause mechanical destruction of the skin and subcutaneous tissue. This tissue damage results in localized hypoxia and the release of inflammatory markers and can be extremely painful. Most at risk include the hands and feet, ears, nose, cheeks, and penis. Risk factors are listed on this slide. Symptoms include numbness and tingling, clumsiness, and excruciating throbbing pain on rewarming. Superficial frostbite involves only the skin and not the subcutaneous tissue. It typically results in fluid-filled blisters, and the skin will indent with pressure. Deep frostbite involves both the skin and subcutaneous tissue. Blisters are blood-filled, and the skin does not indent. The treatment for frostbite is rapid rewarming. Do not thaw the skin unless you know that it won't freeze again, as refreezing worsens the damage. Serous blisters contain thromboxanes and prostaglandins that damage tissue. These can be debrided and treated with aloe. Hemorrhagic blisters, however, should not be opened. Be sure to also watch for contractures and compartment syndrome. The sequential treatment for frostbite can also include ibuprofen, 400 milligrams by mouth twice daily, which can help reduce swelling and maintain vasodilation, as well as IV low molecular weight heparin and penicillin for 72 hours. Frost nip is the superficial formation of ice crystals. It does not cause permanent tissue damage. However, pain can last up to 2 to 4 weeks. It is more common in women. Symptoms include red, itchy, painful skin, and sometimes blisters. Treatment is ceasing to be in the cold. The good news is that again, with careful planning, medical conditions from the cold can be avoided. Plan ahead, layer up, and make sure patients are fit, well hydrated, and nourished for their operation. Remember the 3 L's: layers, loose, and lightweight. Keep your clothes dry. This means waterproof external layers are important. So now it's time for a knowledge check to see what we've learned. Question 1. Understanding the atmosphere is important for aerospace medicine physicians. Which of the following is false? A. Rockets are required above the Kármán line due to loss of aerodynamic control for airplanes. B. Crewed high-altitude balloons reaching above Armstrong's line require pressurized suits. C. The percent oxygen composition of the atmosphere decreases at Armstrong's line. D. Atmospheric pressure decreases with increased altitude. Or E. The thermosphere warms up because of radiation. The correct answer is C. Remember, the percentage of oxygen does not change, but air density decreases, meaning air molecules are more spread apart as the partial pressure decreases. For question number 2, let's look at a case. You are in a group hiking Mount Kilimanjaro, the highest mountain in Africa, with a summit of 19,340 feet above sea level. You start your summit ascent from base camp, approximately 15,000 feet, at midnight to make it to the top and back down before the thunderstorms roll in. No one feels particularly hungry along the way, and each of you has been struggling with a slight headache the last few days of the hike, despite 2 nights at 12,500 feet. As you are approaching the summit, one of your companions is feeling a bit nauseous. Then suddenly he proclaims that he just saw a domestic cat run across the trail. When questioned about it, he insists that is what he saw. There are no cats living at 19,340 feet. Question 2. What is the most definitive option for our individual with hallucinations of cats on Kilimanjaro? A. Rest, drink some fluids, and reassess in the morning. B. Dexamethasone. C. Acetazolamide. D. Descend immediately. Or E. Tell them they are crazy. You want to summit. The correct answer is D. This patient is displaying altered mental status, which distinguishes HACE from AMS. Although a few of the answers are appropriate care, the most definitive management for what is likely high-altitude cerebral edema is to descend immediately. Dexamethasone can be given as a temporizing measure, but descent immediately is still the best answer. For question 3, let's look at another case. You are at a desert location performing simulated extravehicular activities in a new spacesuit mock-up. It is 104 degrees Fahrenheit outside with a heat index of 112 degrees Fahrenheit. The cooling system in the spacesuit has just malfunctioned. The subject in the spacesuit complains of feeling dizzy and is slurring their words. The operation is paused, and when the subject removes their helmet, they immediately start vomiting and fall to the ground. Question 3, what is the diagnosis? A, heat cramps. B, heat exhaustion. C, heat stroke. D, exercise-induced hyponatremia. Or E, gastrointestinal illness. The correct answer is C. This subject is most likely experiencing heat stroke due to altered mental status, dizziness, and vomiting. The best course of action includes to first confirm the diagnosis with rectal temperature greater than 40 degrees Celsius, then immediate cold water immersion treatment and treating until the rectal temperature is less than 39 degrees Celsius and monitoring until it is less than 38 degrees Celsius for at least an hour. For question 4, let's look at one final case. You are providing medical support in Antarctica. A new 67-year-old cook has just arrived on the ice with your plane. She is not familiar with the area and gets lost briefly outside during the first week due to a snowstorm and cannot find her way back to the station. Her roommate notices she is gone and alerts the authorities, who find her promptly. When they found her, she was passed out in the snow, not wearing a jacket, and smells like alcohol. It has been several hours since you last saw her. She is not shivering and her lips are blue. Question 4. What is her class of hypothermia and matching treatment? A. Mild, remove wet clothing and give warm oral fluids. B. Mild, hypothermia wrap. C. Moderate, passive warming, warm oral fluids. D. Moderate, warm IV fluids, flush with warm Foley. Or E. Severe, warm IV fluids, chest tubes bilaterally, and ECMO. The best answer is D, moderate hypothermia that should be treated with internal rewarming by IV fluids. The key here is that she has altered mental status and is not shivering. You could argue that she is severely hypothermic, which would need further intervention. However, remember that this is Antarctica and ECMO is not available. This concludes this lecture. References are listed here. We'd also like to give special thanks to Dr. Amy Krakis, UTMB RAM graduate, class of 2020, who created the original version of the UTMB Aerospace Medicine Seminar Series. And special thanks to Ms. Heather Medley for her tireless work in reformatting and updating the seminar series as part of the 2024 revisions. Thank you for watching this presentation. We hope that you enjoyed it. If you have any questions, please don't hesitate to contact us at the email listed here. Please stay tuned for our next lecture.